Lumbar punctures.
Yes.
Why are these needed and why do we do them?
Yes. I mean, they've gone up and down in their use in the diagnosis of MS. When I first started out back in the 1990s, we always did a lumbar puncture because it was at that stage one of the most sensitive tests, because you would expect 90 to 95% of people with MS to have an abnormal result. We'll talk about what that means. But, so if it was normal, you'd think, oh, this is unlikely to be MS. So we did it a lot. And then MRI scanners came along and they were so good, we thought, well, perhaps we don't need lumbar puncture. But then they came back and they came back with a vengeance. So we're doing them more and more. And the reason is partly to provide confirmation of the diagnosis, in that, again, if the results are normal, that's an indicator that you may not be dealing with someone with MS, but also because we're using that abnormal result when we find it as a alternative looking at changes in time. So if you remember, we're trying to find a disease that has multiple sites affected over multiple time points. So if we see multiple sites affected and the lumbar puncture is abnormal, it tells us we don't need to worry about seeing further events. We can say at this time, you have MS. So that's why it's coming, because we can make the diagnosis of MS earlier. So that's why we're doing them more frequently now. And especially in the case of people with progressive MS, people with primary progressive MS, where you have one site affected, usually the spinal cord, people getting slowly worse and worse and worse without distinct attacks. It's really hard to say there's been a new thing in time. So we use lumbar punctures as a alternative that's dissemination in time criteria. So we're doing it more and more in primary progressive MS.
And what is it you're actually looking for?
What we're looking for is this phenomenon that's been known about for over 100 years, which is that people with MS have a lot of antibodies in their spinal fluid that you don't find in the blood. And that implies that there's something immunological going on around the brain and the spinal cord that's spilling over into the spinal fluid. However, the techniques that are used are a little different. The old-fashioned gold standard technique will demonstrate oligoclonal bands. That's the phrase that you often see. And that simply describes the appearance on a gel using something called isoelectric focusing of these different antibodies appearing in different lanes. And there's a few of them, oligo, and they're bands because they're on these lanes on a gel, so oligoclonal band. Now, that's a very good technique. It's actually quite hard to do. It takes a trained person many months to learn how to do it effectively. And one of the new things of the 2024 criteria is that we can now use a different technology to identify the same phenomenon. And this technology comes in a kit. This is kappa light chain analysis. So it's a kit that you or I can buy and put a bit of spinal fluid in, and it'll give us a result. So it's not quite as easy as the COVID test that we used to do during COVID, but it's kind of that same easy kit that you can buy and it'll give you a result. And so this means that it's much easier for labs to set up as an MS diagnostic center because they just have to buy the kits in and not have trained personnel.
And is the sort of the procedure of doing the test similar? Or
the lumbar puncture itself is exactly the same.
Mm-hmm.
But the spinal fluid then goes off to the lab and then it's completely different what then happens. Whether it's the old-fashioned technique requiring time and expertise or the new technique requiring someone who can just read the instructions through a kit.
We do know a lot of people are worried about lumbar puncture.
Yes.
Because it does sound scary on paper.
It does.
When you talk to people, you get very varied. Some people say it's the worst thing that they've ever done.
Indeed.
And some people say it was nothing.
Indeed.
Will you talk us through what actually is done?
Yes. So this won't be done at your first appointment. That's the key thing. So don't be worried that you're going to go to that first consultation and someone's going to suddenly stick a needle into you. So it'll be a separate occasion. It may not happen, but you'll get warning. You'll be given advice. You'll be told what's going to happen. You'll come back and you should put aside a day for this to happen. You'll go to a hospital type setting And there you'll lie on a couch and a doctor or a nurse will come along, explain what they're about to do. Then they'll put some local anesthetic at the base of your back, and that will numb the area. And then they'll put a long, thin, very thin needle through the skin, which you'll barely feel, and then between the vertebrae, the bones of your back, and slip it into the fluid-containing sac at the bottom of your spine, where there are no nerves. That's a key thing. It's just fluid. And then they let a few drops of fluid go into a few bottles and then pull it out. So if it all works swimmingly, it's done and dusted in 10, 15 minutes. Yeah. And then usually people are asked to lie flat for an hour or so, and then they can go home. That's it all going swimmingly. Now, what can go wrong? What can go wrong is that it can be difficult to do, particularly in older people where the bones of the back are a bit worn out. It can be hard to find that little area. So some people find that it can take 2 or 3 attempts before there's success, or that there's no success at all. And that can be quite traumatic, both in terms of the feeling of it, but also the feeling that the outcome that we haven't achieved what we wanted to achieve. The procedure can go fine, but then you can get a side effect. And the most common side effect is a headache. And that might happen in 10 to 20% of people. And it's a very particular form of headache, because it's a headache that gets worse if you stand up and gets better if you lie down. And the simple way to think about this is that if you've taken some fluid out of the spine, there's less fluid also around the brain. So if you stand up, your brain gets a bit dehydrated. Not very scientific, that's the experience. If you lie down, the fluid washes over the brain again and you feel better. Right. Now, the way this normally works is that people get better after a few days without anything. So almost always people say that the experience was far better than what they feared from a lumbar puncture.
So you already said lumbar puncture was very in fashion and not in fashion. With the new criteria, are we likely to see less of them? Or
I think possibly marginally less. And the reason for that is that we now have this new clause where if an MRI scan looks so characteristic of MS, with 4 areas typical for MS obviously involved, then we don't need to do any more. We don't need to demonstrate that multiple episodes, the dissemination and time. So that's taken away the need for a lumbar puncture at that point. But we'll still see quite a few when the MRI scans aren't the slam dunk that I've described, or someone has a progressive syndrome and might have primary progressive MS. So I think lumbar punctures are here to stay for a long time. If you're over 50, it's very likely that your neurologist will request a lumbar puncture, because that's when the MRI scans become less useful diagnostically. And the neurologists will be looking for other ways to confirm this is MS.
Why is a lumbar puncture particularly good then for diagnosing progressive MS?
Yes. So the problem in progressive MS is that the person who has that form of the disease has one area affected, usually the spinal cord, causing problems with walking typically. And that gets very slowly worse. And you can't indicate the spread over time of this disease because there's not another attack affecting another site. And so that's when it's really helpful to have the oligoclonal bands or the kappa free light chains demonstrated on a lumbar puncture, saying this is MS and it's an ongoing disease. So you have activity in time.